Welcome to the Medtech Insider, where we take an inside look into all things med device. My name is Parker Snedden. I'll be your host. And we're going to talk about the power of partnership today between an APP and an interventional pain physician. I have two distinguished guests, one to my left and one to my right here. At the Spinal Simplicity headquarters here in Overland Park, Kansas, Dr. Dan Kloster, interventional pain management physician, anesthesiologist, owner of two practices here in Overland Park, Kansas. Welcome to the show.
Thank you.
Glad you're here. And then Morteza Rabii, we're going to call you Mort today. How about that? Yeah.
Yep.
Mort is an APP nurse practitioner, works directly with Dr. Kloster. Gentlemen, it's great to have you on the show today.
Thank you.
Glad to have you.
Always a pleasure.
Yeah, absolutely. Let's dive right into it. There's been, in my mind at least, a pretty seismic shift in interventional pain the past, 2 to 5 years. With new interventions, COVID has changed telehealth interactions with your patients. AI has come into the healthcare space.
Yep.
I just want to get your guys' take, and I'll start with you, Dr. Kloster. How has the interventional pain job for you changed in the past 2 to 5 years in your mind?
Yeah, no, it's been absolutely great. I've been doing this a long time, right? So I've been doing this for 25 years, and that's a while. And so growing up in the interventional pain space, we had 3 epidurals, we had RFA, we've had stimulators, we've had pumps. So those were kind of the tried and true. And there's some people that were more comfortable with that than others. But over the last 5 years, it's really been exciting just to see the outcomes of these minimally invasive procedures. So now we're doing these spinal procedures that you guys offer. Other companies are in that realm. We do sacroiliac fusions. You have, there are other companies as well, but it's the outcomes that we see from this has made it so exciting. You see, and it's meant for us. So interventional pain, we are the experts in fluoroscopy. So we do all the fluoro guidance, so live x-rays. And if you talk to anybody my age, but even has been well-trained, and a young guy just coming out or young gal just coming out, they're the experts. They do injections, maybe 10 a day to 20 a day. And so when you have that repetitive nature, now you get a device that you guys have put together, that Spinal Simplicity has done so well, and that's in our wheelhouse. And now we can affect patients so dramatically. So for me, the last 5 years, it's really been the newer devices on the market that's minimally invasive, meant for us, and we get to see the outcomes. I mean, it's amazing to see a patient before and after some of these procedures.
Yeah, I love that. More, how about you? So you get to see the patients every day. Yeah. How has it changed in your mind?
Kind of echoing what Dr. Kloster was talking about as far as, the minimally invasive treatments offered nowadays. Prior to being in interventional pain management, I did orthopedic surgery, worked part of that time with spine, very passionate about this patient population. And it's been very interesting to see in the last 5 years, these patients that have essentially been suffering from this benign neglect, right? They're not so far gone. They don't have, a myelopathy. They don't have anything that requires a large surgical intervention, or maybe they don't want a large surgical intervention. They're not healthy enough for a large surgical intervention. But the injections, the radiofrequency, the pain pills just wasn't getting them what they needed from a relief standpoint. So now having these interventional spine, these minimally invasive procedures that can really help give patients durable long-term relief has been very interesting to be a part of. Very passionate about identifying these patients right and figuring out which ones should go, for what type of procedure, which has been very empowering as an APP as well on my end.
Yeah, I love that. It seems like this technology, not only from our company, but others, has really been catered right for you guys. Yeah. It's right there for you. And so it's an exciting time to be a part of this market, I think. It's really fun. So I want to talk a little bit about your why. We talk about that here at our company quite a bit. Why do you do what you do? And so you're studying, there's lots of specialties, Dr. Kloster, that you could have chosen.
Yeah.
Why anesthesia? Why interventional pain? What drew you to that specialty?
Yeah, so I can give the long answer. I'm going to try and keep it short. But my father's 91, retired general surgeon, grew up in rural North Dakota, and that's when men were men and giants walked the earth, right? So I had a different upbringing. So I was actually in the operating room at a relatively young age. It was a town of 1,800, and you knew everybody. And
Is that the year you started in the operating room?
yeah, exactly. And so, but I was just going to be a surgeon. And so I went to med school and had actually started going for surgery interviews, and I took anesthesia in December of my fourth year of med school just because, I figured should know what the anesthesia people do, and, just had misconceptions. They didn't do much, right? And they just kind of sat up top and whatever they do. And I absolutely fell in love with it. It was a lot of physiology, which I loved, and very interventional. I mean, you were doing, not just IVs, but other things. And I remember calling my dad at 3 a.m, and I said, I'm canceling all my surgery interviews, and I'm going to do anesthesia. And he said, best goddamn decision you ever made, and go back to bed. And so I interviewed.
So he was okay with it?
He was, always supportive.
Yeah.
And so I interviewed at one place, and so that no one does that. And so I interviewed at one place because I had missed all the interviews, and I was doing my anesthesia KU and Rock Chalk, and
Yes.
So they said, "Yeah, listen, we have a spot for you." And then through that, I got exposed to pain, and everyone hates pain. There's nothing but drug addicts and miserable people, and why would you do that? And I got exposed to that at KU, and there was a couple staff there that were good at it. And I'm like, wait a second, these aren't all drug addicts. They aren't all miserable people. These are really good people that just are trying to get back to work or help out around the house. And so the second epiphany and same deal, I was like, wait, I really like this. And so, I had no intention of doing it, but then again, interviewed at one place, and a different story that I'll shorten up, but I interviewed at Harvard and one place again. I guess I'm just kind of a fatist. Either things work out or don't. And they said, yeah, well, happy to take you. And, the rest is history. And when I'm old enough, I thought I was going to do anesthesia and pain when I came out. And the reality is you can't do both. It's just you have to pick one. And I loved OR anesthesia. I thought I was good at it, but I really loved helping people in pain. And, I'm a talker. You guys have seen that. And so I love the camaraderie in the OR, and Mort can probably attest to this as well. There's a different environment. It's friendly. It's a lot of, good acquaintances, but I really like the patient care and seeing how I can improve their life.
Yeah, I love that. And even back to what we talked about at the beginning, that it has changed so much since you started. So I'm sure when you initially chose to be in this specialty, you probably never thought it would be the way it is now, did you?
No, I mean, again, so we had stimulators were around, absolutely. Pumps were around, absolutely. But it was really epidurals and radio frequency. And, if you were an interventional pain doc, that was more of a rarity. There, a lot of medical management, which we do and is absolutely important, but a lot of the other physicians, when I was doing this, they just weren't interventional people that just didn't do RFA. They do epidurals, but no radio frequency. And it was kind of interesting, but then I had built a niche business in Kansas City, and so Mort and I manage a lot of intrathecal pumps, which I'm very passionate about, and that is very intimidating for a lot of physicians, but it's life-changing for patients. And but back to the last 5 years has been really fun from a patient attitude, wanting minimally invasive things, quite frankly, but what we can offer them.
Mm-hmm. And Mort, you started, I know, more on the orthopedic side, and then moved into interventional pain. So maybe the market changing hasn't been quite as abrupt for you because you were sort of used to that maybe at the beginning. But why did you move over into interventional pain, and how's it been the past 4 or 5 years, I guess, for you, right?
Yeah. So good question. And I wish that I could say that it was a situation, an epiphany of, hey, look, I don't want the on-call hours that come with orthopedics. And I, love the patient interaction, which I do. So that is a plus, definitely that long-term follow-up. But honestly, it was a little bit of happenstance. I was applying for a lot of orthopedic jobs out of NP school, was not getting any of those. It Turns out it takes about 6 to 9 months for the entry-level NP out of school to find a job in most markets. And a surgeon that we continue to collaborate with nowadays, I texted him out of the blue. I was frustrated with the job interview process and said, hey, do you have any docs that would be interested in an APP? Said, yeah, this guy named Dan Kloster just mentioned needing an NP, his first NP, yesterday. So let me get you his contact information.
What timing, man?
Yeah.
Wow.
No, literally. So
I
we
didn't know that
set
story.
up interview, and here we are. But turned out to be the best decision that I've ever made. One, because I'm gainfully employed, at least until tomorrow, now that this story's out. But again, it's given me the opportunity to really have that long-term patient interaction that you don't get in a surgical setting. And also, I think there's a lot more opportunities for autonomy and advanced practice as an APP in pain management.
Yeah, I love that. Let's peel the curtain for our listeners a little bit for you, Mort. And as you're interacting with Dr. Kloster and you guys are taking care of patients, just take me through how both of you collaborate to help your patients in your practice. Maybe just like a normal Tuesday or a Wednesday.
Sure.
How do you guys work together to take care of your patients as an APP and an interventional pain physician?
So there's a lot of different models, I think, out there as far as, how, an APP and a physician are going to interact. In our office, we're pretty laid back in a lot of things. I mean, I generally see most of our new patient consultations, a lot of our follow-ups, which is pretty typical, I would say. But we've been working together long enough. I think that for the most part, Dr. Kloster trusts my decision-making on different procedures. So,
Most days, right?
Most days. Yeah. Again, tomorrow might be a different story. But can identify the patients, identify treatment, different injections, which I then refer over to him to get that done. And then either one of us will divide and conquer, see the follow-ups. And, it's nice being able to share an office space together as well, because if either of us have any concerns, questions on imaging studies, we can just kind of bounce that idea off of each other.
Yeah, I love that. That was 4 years ago, 5 years ago?
Yeah, so November 2019.
2019.
We started.
Awesome. So he's your first APP you hired.
Correct.
How did having an APP more specifically change your practice back then?
Yeah, no, listen, it's, to say what Mort did, it's been like, a great marriage. It's been very productive for both of us. But from my standpoint, I do teach for companies. I have 4 kids and they're now getting older. I've got one left in high school about to finish, and others. And, so the scheduling just gets to be a problem. And I've never had an exclusive at my hospital, but I do about 95% of the business. And when you do chronic care, and my nurses, I love them. They're beyond fantastic, but I would take time off and they would have to take time off. I mean, so I'm doing all that. So I really felt bad for that. And my schedule's getting more, chaotic with, vacation or moving some kid into college or out of college. And so it was just really the right time. And so back to being a fatist where, things just work out. And when I told Dave, I was looking for an APP, he's like, hey, I got the great guy, because Mort had done some of the training with them. And so it was just really good timing. So now with the schedule, we can we have somebody on site at both clinics basically 5 days a week. So the staff is important to both of us. They don't have to worry about getting their hours. And so that was kind of the impetus for hiring. Now, to take it to the next step, back to North Dakota upbringing, is, some of the people that I know never went to college. They were farmers, but some of the smartest people I know. And so what was important to me was just finding someone who is smart and can, be the independent person. So I've never had a personality that I've wanted to handhold anybody. I'm very happy to relegate, but you also have to relegate with confidence. So not everyone has someone they can be confident in, right? And so once that was established very early on, it's just, I don't worry about the decision making, right? And now the next part of it, where it's these minimally invasive procedures, I do spend time in the OR. And we're trying to help a lot of people. I mean, I always joke with other people that if I get hit by a bus tomorrow, Kansas City's not going to shut down. I mean, there's plenty of providers out there, but at the same time, we're a very busy practice, and if I'm doing a busy Monday in the OR, I can see 8 patients. Okay, that's no clinic, but there's people that want to see us, and we've never wanted to be the clinic that says, oh, you can see us, we have an opening in 6 weeks. When you're hurting, it's really important that you can get into us, and so we have the ability for somebody to be seen very quickly in the practice. And so me seeing 8 patients on a Monday, when we see generally probably between the clinics, I think we see probably 40 to 60 a day, and if I'm alone seeing 8, and listen, there's a lot of quality physicians out there, so I don't want to make it all about me, but I do think we're good at what we do and very good at what we do, and people do want to see our clinic. And so to say that, oh, we can't see you for 6 weeks, it would just be a different world if I didn't have, quality APP and another partner as well.
I think there's a compliment in there, and I'm going to take it. Thank you.
I might have misspoke.
No,
I love that. No, that I mean, that's what we're talking about today, right? Is the power of partnership and its practices. So I really like that. So Crimson Pain Management, Pain Care, let's talk about those practices. And more question for you first maybe is, what makes you guys unique in what you offer? So if I'm a patient right now in Overland Park, Kansas, I'm in pain, I'm Googling, like how do I help my low back pain or knee pain? What do you guys offer that might be a little bit unique and different than what other practices, maybe not even just in Overland Park, but in general? How are you guys different?
That's a good question. Variety.
Yeah.
Right. I do think there's, again, my background, orthopedics, both of us have been doing spine care and stuff like that, but I do have some background in joint pathology as well. So, between our 2 clinics, we have a wide variety of options for, knee arthritis, hip arthritis, shoulder issues, spine issues, the abdominal pains, kind of persistent pain following surgery. So we have a lot of different things that we can offer patients. With pain care as well, we do have, one of the areas that's getting a lot more research, a lot more study nowadays, regenerative medicine. So truly, between our 2 clinics, I think we can offer a truly comprehensive pain portfolio for the patients in a Kansas City area.
Love that. Dr. Kloster, what do you think?
Yeah, and so everything Mort says I agree with, and I think our strength truly is the education process.
Yeah.
And we pride ourselves. I mean, I love educating patients about what's happening, and to complement myself and my practice, we have seen patients that have had 1, 2, 3 back surgeries. They've had injections, they've been elsewhere, and they come with us, and we sit them down and get a skeleton out, and we say, this is why you do this is why you do this. And so my joke with all my patients is that you got bad spark plugs, a flat tire, the bumper's hanging off, and a cracked taillight. And the reason I use that silly analogy is treating the spark plugs does not treat the flat tire. And a lot of people come in and think they have one problem. And it's like, no, you don't have one problem. But when they start understanding it, and then when they get up at the end of the interview, they will oftentimes say, no one's ever told me this before. Their pain might be a 9 when we start the conversation. I've done nothing but educate them, and they walk out at a 6, because when you understand that, what you have, and you can now, say, oh, okay, I understand what the pinched nerve means. Oh, I understand what a facet joint is. I understand what spinal stenosis. It really, you can just see their anxiety kind of lessen. So they're still in pain, but before we've done anything, they feel better. And so I do think that that's my most prideful thing with our practice, is that we really feel it's important to educate everybody about why you're hurting.
I love that. So let's move the conversation a little bit into some specific technology. We talked about how the space in general is evolving, gives you guys more tools to help your patients. So just for our audience to start here, Mort, can you explain to me what is Minuteman? What is Liberty? And then we'll get into how for you, Dr. Kloster, after Mort answers here, like how has it helped your practice and helped your patients? So what is Minuteman?
So Minuteman is a lateral approach, posterior interlaminar fusion device. It is, to my knowledge, the only lateral approach interlaminar device out there, which is very valuable because you can stabilize the level of the spine, help treat some angular instability issues, some claudication, some radicular symptoms coming across laterally without damaging a supraspinous ligament, without violating the multifidus, and really creating some of the least issues with the anatomy that you can with that kind of a procedure. And then Liberty, so it's an SI joint fusion device, lateral transfixing, so very robust procedure there. The big draw there, what's pretty interesting is the ability to accomplish a good surgical outcome with a single implant, which, again, less tissue trauma, et cetera, for the patients.
Yeah, I can tell you educate patients every day, and you're talking about this. That rolled off your tongue pretty quickly there, man.
I try to do my homework.
Yeah, I love it. I love it. So how is technology like this being introduced into interventional pain? How has that helped your practice, Dr. Kloster, and the tools that you have now?
Yeah, and so back to, being an older guy now is when I did my anesthesia training, for God's sake, it was back in the 90s, and we had to crack everyone's chest for heart surgery, right? And now you can do a stent with a really good outcome. And that's kind of where a lot of this technology has come, is there's big back surgeries that are needed, absolutely. I mean, my guess is we send at least 1 or 2 patients out of our practice every day for a bigger construct, and they need it. But oftentimes we can be more on the stent side. We can offer these minimally invasive procedures that the beauty of the minimally invasive procedures, one, again, educating the patient, but when you find the right patient, spinal stenosis, we all get it, right? So the other silly analogy I give my patients is if you built a house yesterday, brand new pipes. If you built a house 60, 70, 80, 100 years ago, you get corrosion in the kitchen pipes, okay? You don't care if you have corrosion in the kitchen pipes as long as they drain, but if they back up, now we care, right? And so that's an epidural. So you throw some Drano down there, and most people do pretty good. That's why you do it. But then what happens when you say, well, it was great for 2 weeks, or it was great for a month, but now I'm miserable again. So when you get that, now somehow you have to get that pipe bigger, right? And historically, that was a bigger surgery. You would do, it's called a laminectomy. You cut out some bone, but that leads to a host of problems. And so by doing a Minuteman, we can make that pipe bigger with a little incision. And the most important thing is they go home the same day. So in the medical world, it's called disposition, right? So if you have a bigger back surgery, you're a day in the hospital or maybe a week in the hospital. You're a day in the hospital, 2-3 days in the hospital, and then you get discharged to a rehab facility. And one of the other things that has really been beneficial over the past few years is seeing patients become more educated. I think when I first started doing this is everyone said, I just want it fixed. They didn't understand the anatomy. They just thought if they had a big back surgery, you're done. Well, you can't untotal the car, right? And so now patients will come, and Mort and I have had the same experience, and I'll be like, you need a bigger back surgery. And they're like, I ain't doing it. And you were like, no, you need it. I mean, I can't really help you. It's like, I ain't doing it. So you get that group of patients that are now coming more educated, and they understand. They're like, listen, I have a cat. I live by myself. And you can laugh and make it sound silly, but watering your plants and having a cat, you can't be 2 weeks in rehab, right? To do that. And these are real life decisions that now people are understanding beforehand. And then some that aren't understanding, they think, I'm just coming back surgery and go home. And it's like, ask your surgeon what the disposition is. And so by doing this minimally invasive for spinal stenosis, we can, again, just capture a really good outcome. And then the SI, the Liberty, to pair what Mort was saying, is we're stabilizing the SI joint. And it's funny, when I was doing this, we never even looked at the SI joint. And the reason we didn't look at the SI joint, we couldn't do anything for it. So if you don't have a treatment for it, it doesn't exist. Okay, so obviously the SI joint has been painful for millennia, but if you met me when I finished my fellowship, you didn't have it because I wasn't going to diagnose something I couldn't treat.
Nothing you could do for it at that point.
So it was just off my radar. I'm like, I'm not, you don't have it. And so, but now we know that it's truly one of the most debilitating pains out there. So in those patients are people that had prior back surgery. That's a big population, or a gal that's had a kid or two, and now they're in their 60s and 70s. And those two are big risk factors for having sacroiliitis or sacral dysfunction. And it truly is a debilitating pain. These are people that it ranks up there with having Parkinson's disease or congestive heart failure. It's that debilitating. These people are miserable. And, Mort's our SI expert, and he'll do the injections on them, and they get the recovery room, and they're like, I haven't felt this good in 5 years or 10 years. And then the problem with that is it's tough to get lasting benefit, is the joint is so tight. You can get them great relief for a day or two, but once we know that's great, now it's pivoting to the fusion. And it's such a nice, safe procedure for me. It takes me, less than a half hour, and it's just a predictable outcome. So we're always surprised if people don't do as well. So you never promise, neither one are dumb enough to promise an outcome, but we're always surprised they don't do well because the diagnostic blocks are so dramatic for these folks. And then you get to the Liberty specifically. So for that product, you have plenty of competitors, but you don't have a competitor that can do one screw. And from a physician standpoint, when, if I can drive 50 miles, it's better than driving 100 miles. Well, if I can do one screw, okay, it's better than doing 2 or 3 screws. So, time is, precious to all of us. And if I can get a good outcome and half my OR time for that specific patient, that matters.
Yeah.
And so that's why, I'm a fan of the Liberty.
Yeah, we were talking about that. I love that. We were talking a few weeks ago in Atlanta, I think is the city we were in, right? Where you were teaching. And I love that story because you're thinking about your patients and them potentially being able to most of the time go home the same day after Minuteman.
And go home the same day. Yeah.
There's not a long-term rehab.
No.
That was fascinating to me to think about, where this minimally invasive option for them allows them to go home and water their plants, take care of their pets, be with their family.
Right.
And I think that's kind of why we're all in this.
Right.
Is to help them with that. So I love it. Well, I want to talk to you about those patients you mentioned earlier, the benign neglect, and maybe the patient who has had injections, had conservative care. We're talking about maybe someone with radiculopathy or neurogenic claudication, but they're not probably a candidate for open surgery. Let's talk to that patient where they might be going, what do I do now? Minuteman could potentially be an option for them. But for a patient that doesn't even know what that means, like how you see them every day. So who is that patient? And talk to me about those patients.
I think those patients, several of them, right?
Yeah.
So it's the biggest group is these patients that they're in their 8th decade of life, 9th decade of life, right? They're elderly. They either refuse to have any kind of surgical procedure. They're like, I just don't want to do that. Or, they've seen prior pain physicians. They've gone on to, did not get long-term relief with injections. They gone on to see a surgeon who said, yes, we can do X, Y, Z. No, it's not required, but this is what I can offer you. And, they balk at that offer, so, those patients that do not have any sort of neurologic deficit, I mean, that's a home run patient, or at least a potential for a home run patient. One of the first things, we talk about them, I ask them is, okay, how do you do once you lean forward? How do you do once you sit down?
Yeah.
Your symptoms go away? Great. Okay. So what you're doing in that situation is you are decompressing those nerves. You're decompressing, you're restabilizing the alignment, the forces on your disc. You're restabilizing that spinal segment. Now, if you could stay in that position, that kind of, take the pressure off, and we could make that more permanent. We could actually stabilize this, lift some pressure off of those nerves, and make this long-term through an inch and a half incision under MAC anesthesia, so colonoscopy style, You're healthy enough to have that. You just did that last year. I saw the report. Congratulations, you're polyp-free. But, this is something that we can do. You've had the injections. Unfortunately, didn't get the therapy you needed. So this is an option. It's relatively quick. We are not causing significant change to your anatomy. And that's kind of where we go from that.
Yeah.
And a lot of times you put it in their hands, like, if this could reduce your pain by 70% in the legs, potentially more, some improvement of your back pain as well, would this be worth it?
Yeah, I love that. And again, it's a tool that you guys have now. And certainly we all know there are patients that are going to need, to your point earlier, Dr. Kloster, bigger surgery. But now you guys are both such great educators and can talk to your patients about these different options now. So I love that. Let's take a fun, quick break here. But let's not talk about healthcare. I want to get to know you guys personally a little bit with some fun rapid fire questions. Okay.
Okay.
So we're going to call this rapid fire clinical edition. All right.
Okay.
First of all, Mort, we'll start with you. What's your go-to getting up in the morning coffee order? You're going to Starbucks or maybe it's a local coffee shop. What do you like? Or is it tea or 5-hour energy?
Black coffee
Yeah.
from the French press at home after workout. Great way to start the day.
I love it. Dr. Kloster, how about you?
Black coffee with a little bit of skim milk.
Okay, that's great. So keep it simple.
Yep.
I love it.
That's it.
All right. So for you, Mort, what's Dr. Kloster's most used clinical phrase? It can be in the OR or when he's seeing patients. What do you hear him saying all the time?
Does it have to
Keep
be
it clean.
Phrase? To be a phrase?
A word, a phrase. What does he say?
I mean, is routinely humming "Fly Me to the Moon" or whistling that often. So it's
so
not
you're a
phrase.
singer throughout the day.
I don't
Just
know
kind of
what we call
whistling.
that.
I love it. Not quite singing, making noises.
Exactly. Yeah, exactly.
That's so good. All right, so we've been talking around the office. If you had, so when you play baseball, are you guys baseball fans?
Yeah.
Okay, Royals fans maybe?
Yep.
So when the batter's walking up to the plate, they have a walk-up song, right? So if you were to have your own walk-up song, let's say you're walking into the OR, Dr. Kloster, or maybe I've been to the OR with you. You have music playing sometimes.
Yeah.
What's your song or what kind of music would you like as your walk-up song?
Well, I'd have to be "Fly Me to the Moon," right?
Yes.
I mean, So, no, I'm a big jazz guy, so I can't name a song, so I should have a better answer for that. But I listen to jazz every day,
yeah.
and that's what's going on in the clinic. So Mort's sick of it because you ask him about his classically trained being a cellist, but he has to listen to jazz every day in the office when I'm there.
Oh, that's awesome. Do you go down to 18th and Vine very often?
Now, back in the day, I used to.
Yeah.
Absolutely. Yeah.
That's fun. More walk-up song. What do you think? Oh, he's going to play it. That is awesome. Is that your ringtone every morning?
Absolutely.
Oh, that is so funny. All right. Who is most likely, I could probably answer this question because I witnessed it today. Who's most likely to be early?
Oh, God.
This guy.
That's not a question.
No.
That's a fact.
Not at all.
Which one?
Me.
Yes.
I mean, to his point, that I don't know if he's working the day or not. So,
Until he shows up?
Yeah, he wanders in. I'm like, is Mort here today? So in fairness, I mean, he can tell you about his children, but
That's
they're
amazing.
younger than mine.
There's no doubt about that.
Yeah. So
Yeah, you
were
do
on
seem
time.
pretty punctual, Dr. Kloster.
I am
You're there. You were on time today. This guy, not so much.
No.
To be fair, I believe he was with one of your patients, right?
it's our patients.
Yeah.
Yes.
So,
I think, one of your patients together. We're talking about collaboration
exactly.
today.
So,
It's our patient.
Yes. I love that. Okay. That was fun. That was good. Good to hear those good answers. That's good. Walk-up song, I think, is a great question. Jazz. That's so good. I love it. Okay, let's bring it back to your practice. Let's talk about the patient who might have had some conservative therapies, but they're nervous about like what that next step is, Dr. Kloster. Maybe they've been researching some of these MIS options, but they just are nervous about what that next step is. How would you speak to them about, you've done a lot of these procedures now over the years, so how would you speak to them?
Yeah, I mean, the same thing, just educating, right? So, listen, I'm not a mechanic, right? So if I bring my car in, I just have to trust what the person's telling me, right? And we get the good vibes and the bad guys. Bad vibes. You're like, okay, that guy's just, he's not nice, or, use a more blunt word than that. It's like, but then you get a person that educate, oh, this is what's wrong with the car. This is what we can do today. This one probably needs to be done, And so we're kind of that way with those patients. So there's a lot of patients that are nervous, and I tell patients, you don't have to do anything. So I reassure them that this is not cancer, it's not a heart attack, right? You got spinal stenosis, a common problem, but this is what we can do to address it. And then, I say, listen, if we do nothing, it's not going to harm you. There's just between hurt and harm. But once you get the model out, once you get the skeleton out, once you kind of have this banter back and forth, and we do this. I mean, we are a very relaxed clinic, and we talk to our patients like we're talking here, and they all of a sudden they're just like, oh, well, that makes sense. Once you understand, right, things are not as intimidating. And so, and then back to experience does matter. Now, there was a time when I did one of everything, right? There's a time I did one epidural. I did one spinal cord stimulator. Now the numbers are just crazy. But I think I'm over 300 Minuteman now. And that matters when you're talking to patients, because out of all those Minuteman I've done, back when I started this, they would have all been candidates for a laminectomy, a bigger surgery. And I think we've sent, out of those 300, less than 10 on to surgery. And that's a pretty impressive stat when, not everyone's a home run. I don't want to give that impression, but a lot of them are. But they've had enough of a result that they're like, listen, this is great. Yeah, I don't need to have the next step. And so, you figure about 290 to 295 did not require a bigger surgery, and they would have been when I started my career. And even, a decade ago, I would have been sending them. I would have said, hey, you need a laminectomy. You need to get that pipe bigger. And so it's really the education process. And once they're educated, once you understand anything, you just feel more empowered to make a decision.
That's good. How about you, when you talk to a patient like that who might be nervous about something that's more invasive, certainly, than an injection, not as much as open back surgery? How do you speak to them?
I definitely start, like Dr. Kloster was saying, look, you do not have to do anything. But kind of working on what their functional goals are. Okay, what do you want to be able to do? What is this pain getting in the way of you doing right now? Okay, you've done these injections. Felt great for a couple weeks. You felt great for a month. Now you can keep doing that. Okay, Medicare, look, we can do 4 of these a year. But is 4 months out of 12, is that worth it for you to continue down this road? A lot of patients are like, that's not exactly what I'm looking for in a day-to-day life. Okay, so this is the next step that we can do. We can address some of the structure. The reason why these injections are no longer offering you the benefit, is because you have a structural problem. So how do we change this? How do we improve the space? How do we, stabilize your spine with the least physical footprint as possible? And in our clinic, this is what we have to offer.
Yep, I love that.
And I'll just add too, one thing that we tell people is, some people have seen a surgeon or we're going to see a surgeon. The nice thing about this, we haven't destroyed anything from a bony architecture standpoint.
Exactly.
That if they don't get the result they want, they can still have a surgery, and it's really not in a surgeon's way. I mean, we know many surgeons, good friends, and we teach with a lot of them, and this is just something that's not in their way. If they're doing a laminectomy, they just take this out anyways. And so when you let the patient know that it's not a bridge too far if we do this. So it's a minimally invasive option with an expected good outcome. But if we don't get that good outcome, you still have other options, more traditional options, and it's no harm, no foul.
Yep, I love that.
Actually, we've known a couple patients that fell into that category and unfortunately did not get the results that they were looking for. But, surgical colleagues actually came back and said, hey, look, we appreciate the fact that this level is now fused. It kind of needed to be.
Yeah.
But, they went around and just kind of did a hemilaminectomy, worked around
Yeah.
the Minuteman, and, were able to create a little bit more decompression. The patient continues to do very well.
Yeah, no bridges were burned at that point. So shifting the conversation a little bit to Liberty. So there are maybe some misconceptions or thoughts out there on the safety profile of the lateral approach to SI joint fusion. You adopted this into your practice about a year ago, I think it was. Talk to me about just your opinion on the safety profile of the lateral approach to SI joint fusion. Now that you've done quite a bit of these, what are your thoughts on it?
Yeah, it just comes back to education. And, listen, there's good publicity, bad publicity. And so it's an incredibly safe procedure. And so if you don't do these, and before Liberty was even released, I was doing laterals with companies, and there's a lot of great companies out there. And so I've been doing laterals because I truly think it's the most consistent approach and the safest. And so if if anyone wants to delve into this from the medical community, the gluteal artery is what you call it fake news, I guess, in this day and age. It's not in the way at the approach we're taking. Okay. Now, if you don't know anything about the lateral approach, you'll say, "Oh man, but you can get the gluteal artery." And again, it's just, it's not there. If you do the research, it's not in the way of the path we take. Now, I used to do a posterior approach, and so before instrumentation, before we had a screw, we would do cadaveric bone, so allograft, and we got good results with that, but it wasn't a fusion. Okay, so it was kind of a distraction. If you most people can understand knee on knee pain, that hurts. Well, that's kind of the SI joint. If it's bone on bone, it really hurts. And we could put an allograft from the posterior approach and just separate that and got really good outcomes. But they were limited good outcomes. But we'd start seeing those patients back 12 months later, 18 months later, because it wasn't fusing, so it would be rubbing again. And in my opinion, that's quite frankly, I don't want to say dangerous, a very safe approach, but it was not as consistent, because when you do a posterior approach, each SI joint is like a snowflake, right? They're just not the same. And they're just these tortuous or circuitous, and you can actually put the implant through the joint. And you're not harming someone when you do that. And surprisingly enough, they would still get a distraction, but I've done that personally. And you get imaging, later, and you're like seeing it wasn't in the correct spot. But on fluoro imaging, which you're using the OR, it looks perfect. But you get a CT afterwards, and it doesn't look so perfect. No matter what the joint looks like, posteriorly, lateral, there's never an issue. Lateral is 100% across the joint and fusing that joint. So I use the only time I do posterior anymore is if the patient has prior surgery in that area that precludes me from doing a lateral approach. And there'll be some patients that have a hardware construct from a big fusion, and maybe there's a bolt in my way, and then I can do a posterior. But I've truly been all lateral, probably, I would guess, coming up on 3 years at this point. And that's just my preference for the consistency.
Yeah. I love that you are both educators. Yeah. We talk about educating patients on these new therapies who might be nervous, but also you're both educators on the weekends. Yeah. And more APP of the Year by Aspen recently. Congratulations. That's a big honor. Really, really cool. So I'll start with you on that. I know we bump into each other on weekends quite often at these society meetings, and you're teaching not only what we've been talking about today, but other therapies as well. So why is education for you a passion? Why do you go out and teach other APPs kind of the best practices that you've learned?
There's several reasons. Networking, elevating my own game, but most importantly, elevating patient experience and patient care, hopefully throughout the world, or at the very least, in my backyard. These therapies that we offer, these treatments that we have at our hands are very good for the right patient. They work fantastically when patients are selected for well. In the modern collaborative pain clinic, where you have APPs doing a lot of patient selection, and you have the operative arm as the physician, patient selection as an APP is critical. You need to know who you're identifying for what therapy. So if I can help other people to understand that, if I can help other people grow their practice and help those patients that they might have been kind of stuck on this little hamster wheel of repetitive injections in the gabapentin that's making them a little too sleepy. I want to be able to help those providers out. And also, it's nice. There's several of these people that have become very good friends of mine throughout the country. And if I ever have a situation where I'm like, I don't know what to do with this kind of patient, what to do with this situation, after I talk with Dan, of course, then, texting some of these people like, hey, what do you guys do in this situation? So it elevates my game, it elevates the space, and hopefully elevates patient care.
I love that.
Gets me away from the 3-month-old too.
Yeah, and you get to get out of town for a little while and get some sleep maybe.
Yeah.
That's so good. How about you, Dr. Kloster? Why do you like to do it?
Yeah, no, I've always loved to teach.
Yeah.
I think we're both good at it. And couple things. One, I'm not going to be doing this forever. Mort's not going to be doing this forever. And the comment I made earlier, right? If I get hit by a bus tomorrow, Kansas City's not shutting down, right? So other people need to do these procedures, right? And so that's a big deal because they just help people. And so that's kind of the big picture why I want to do it. I just want other people to be, good implanters or whatever therapy. And so we teach for a lot of companies. And then on a personal level, it just really sharpens my skills, and I get to teach with a lot of really bright people. And I've sat through their lectures, they've sat through mine, over the years, and I'll pick up something every time. And it's always a pearl. Everyone wants the pearls, and I'm no different. If I listen to Mort give his lecture or someone else, I'm like, oh, that's a point. It's a point that we just had glossed over, and all of a sudden it's like, wait a sec, that's an important point that I'd completely forgotten about. So it really, I really learn something every time I do it. And so I love teaching. I love the camaraderie and all that, but it makes me, I think, a better doctor by a long shot. But I really enjoy getting people past their own concerns. So when you're a new physician, you might be very talented, but you've never done a Minuteman. You've never done a Liberty. And as a physician, you don't want to hurt anybody. You just don't. And so if you're intimidated by a process, you'll choose not to do it. You'll say, I just don't do it, But a lot of these people that come to these courses, and you see them, and not everyone becomes an adopter, but there's people that they got the skill set, but they're just not confident. Where do you put, where is the trajectory of this pin, or where do we do it? But once you educate them and you just kind of see them just like, oh, this makes all the sense now. And they go back and implement it, and they'll text me and call me. I got doctors all over the country, and they'll text me a picture, but they'll also text me, hey, I did my first one today. Thank you. And it's just, it's a really good feeling.
I love that. Okay, last question. The interventional pain physician or APP just coming out of school, getting ready to get started. You guys have both been doing this for a long time. You're leaders in the space. What would be one piece of advice that you would give a physician maybe just coming out of fellowship right now? What would you tell them?
Yeah, my biggest thing is be willing to adopt therapies. There's a time I did my first spinal cord stimulator. There's a time I did my first intrathecal pump, my first Minuteman. And this space is made for us. So you're coming out, you don't have a lot of experience, but you're smart enough. And so I would just encourage people that, you have to do a certain number before you feel confident. So find a mentor or get to, industry. Industry is very important to educate. And we know this, right? So industry sponsors a lot of these teaching events, but get to the events. Let your local representative know that hey, I want to do a Minuteman, I want to do a stimulator, I want to do a pump, and talk to those people, and then pick the brains of people like me and Mort that have done a lot. But I think you just have to be willing to be uncomfortable but safe. And that's what I always tell patients or physicians when I'm teaching. I say, allow yourself to be frustrated. If you can't be frustrated. You can't be doing any of this because if you can be frustrated, you're smart enough to do it. Be willing to be frustrated, but do it correctly, and then you will get good at it.
Yeah, I love it. Be comfortable being uncomfortable to start, right? And be willing to learn. That's really good. More, how about you? What advice would you give?
Collaborate. You know, as an APP, as a physician, you're new to a space. You know, you're out of school. You've taken your boards. Okay, you're licensed. Congratulations. You are not done learning. Your education is starting.
Yep.
So collaborate with your physician, collaborate with the radiologist down the hall so you get good at actually interpreting your own imaging. Collaborate with your surgeon colleagues to kind of understand a little bit more about this, you know, global spine surgical interventional space that we're in and how we can offer the best therapy to our patients. But, you know, nobody operates well in a silo. So just make sure you continue to work well with the other people around you so you can be and offer the best care to your patients.
I love that. More, Dr. Kloster, thank you for your time today. It's been great to talk about collaboration between an APP and interventional pain physician. Thanks for listening to the Medtech Insider. We'll see you next time.
Thank you.
Thank you.